we are going to get this started recording and introduce our speakers. So we have Lindy Karshner. She's the Trauma Outreach and Education Coordinator for Primary Children's Hospital. In school, she never imagined herself in pediatric medicine, which I didn't either. That's why I just stayed in adults. But after moving to the area, she found her true passion in pediatrics at Primary Children's Hospital. A 15-year veteran of Primary Children's Emergency Department, she has served as a trauma charge nurse for 8 years and led the trauma charge nurse group for 3 years. Teaching has also become a passion of hers, and she frequently teaches PALS, ATCN, and ENPC. Applying her knowledge and experience in pediatric trauma, currently Lindy is excited to establish and develop Primary Children's Trauma Outreach Program. In her spare time, she loves to go on adrenaline-inducing adventures with her husband and 4 kids. She loves to travel to tropical places and spend time in the outdoors. So we'll be hearing from her, and then Jessica Strong is also the Community Health Director at Primary Children's Hospital. She oversees pediatric community health initiatives for the hospital and the Intermountain Healthcare System. These initiatives include hospital car seat programs, community outreach and education, and early intervention programs. Previous to this role, she worked as a project manager in integrated care management and as a healthcare educator in the oncology program for Intermountain Healthcare. She holds a bachelor's degree in health promotion and education and a master of public health degree. In her free time, she loves to spend time with her family, play in the mountains, volunteer with the Girl Scouts, and cheer for Utah football. So Jessica, it sounds like we need to come to you for Girl Scout cookies. And I also love cheering for my Utes all the time. So I am going to turn the time over to both of you ladies and get it started. If you guys have any questions, you can put them in the chat. We'll be monitoring them, or they're going to be pausing and asking questions. So you can definitely come off mute as well.
Thank you so much, Jamie. I'm going to kick it off. Lindy is going to share our slides, and we'll just walk through this. We do have a small group here today, so feel free to jump in, ask questions, put them in the chat. We're happy to engage and make this more conversational. So thank you for letting us join today. We're excited to talk about sledding safety. If you'll go to the next slide, Lindy and I, neither of us have any disclosures. We just do this because, we love injury prevention. Just to give you a little bit of a scope for the national scope of sledding injuries. So this was a recent compilation paper that pulled together sledding injuries from all across the country, looking at the years between 2008 and 2017. And this report found that there were over 220,000 patients treated in emergency departments for sledding injuries. So that's, quite a lot. You'll see that most of those were children. Not surprisingly, I think kids are more likely to be drawn to sledding than adults. But we do still see about 30% of those injuries that do occur in adults. The most common injury that we see is fractures. Not, I guess, terribly surprising, but the thing that I think is really interesting is that this report showed that children were more likely to sustain a head injury or a concussion than adults. And so I'm sure you all that work in trauma and emergency services, you understand the seriousness of head injuries and concussions, particularly for children, that could become a lifelong issue if not properly treated and depending on the severity of it. So this is not a small issue. It is something that we see every year. And so if you'll go to the next slide, Lindy, we have some of our own data from Primary Children's to just kind of show you what we're seeing at our hospital. And again, this is just Primary Children's. And so I'm sure you realize that this probably represents the more acute and severe cases of sledding injuries. I'm sure there are many more injuries that go to their community hospitals and are treated and released that we don't see. But one thing that I think is really interesting is how such a dramatic increase we saw last year. So from 2020 to 21, we saw this dramatic increase in sledding injuries. And while we don't know, exactly why, we have a couple theories. The first certainly revolves around COVID, right? Like we had all been cooped up for 2020, and I think people were anxious to get outdoors. That was, a safe way to, engage, to be outdoors. And so I think there were a lot more people doing outdoor activities. So that's one likely contributing factor. And then the second was, if you remember last year, we had a very dry winter. unfortunately similar to this year. And so we speculate that because we had such a dry winter, the places that people normally go to go sledding maybe didn't have as much snow. So maybe there were more hazards. They were trying new places to try and find the snow. So those are a couple reasons that, again, we speculate, we don't know for sure. But we did see a dramatic increase. And then you can see the purple bar here. This is 2022. Obviously, our winter season is not over yet. And so we do unfortunately anticipate that we will get some more. But obviously there's this pretty big discrepancy between last year and this year, which in a good way, right? Like we don't want to see a lot of these injuries in our facility. But the season's not over yet. So that's kind of where we're at on injuries at Primary Children's. And then I'm going to talk a little bit about tips to prevent sledding injuries. So if you'll go to the next slide. And a lot of these are, kind of no-brainers. But, in my role, we do a lot of outreach to families and schools and things like that, media, interviews. And so these are the tips that we frequently talk about when we're talking about injury prevention for sledding and really winter sports in general. The first is to wear a helmet. And, sledding is interesting because I don't think a lot of people think about wearing a helmet when they're sledding. Like if you're skiing or snowboarding, that's more, I guess, commonplace or acceptable to wear a helmet. But really wearing a helmet when you're sledding is also a good idea because, in that last data, we saw how many of those injuries are head injuries or concussions. And so a helmet will help protect against that. Second, that we always advise for families is to look for hazards. And this could be any number of hazards. This could be, rocks or tree branches. This could be people. But just to be very aware of your surroundings, both as you're going up the hill and as you're going back down, to make sure that you're keeping an eye out, looking for those hazards, make sure that the path that you choose to sled on is safe, that there aren't hazards in the way. And part of that is also being aware of roads. Sometimes we see sledders that, they found a really great hill that ends across at a road. And I'm sure, as you can imagine, that's problematic. We don't want sledders running into the street at the end of their run, particularly because a lot of these sledding devices don't have great brakes. So be really aware and cautious of the hill that you're on and where that hill ends, so that there's not traffic interfering with the fun. The fourth, use a good quality sled in good condition. We don't recommend like the garbage can lid or those little plastic disc things, because you can't control those very well, and again, they don't have brakes. A quality sled is going to be more expensive, but it can give you some of those features that can enhance safety, such as steering and braking. And then with those sleds, again, you want to make sure that's in good condition. So if your sled does have those safety features, make sure that they're working properly. Number 5, look uphill. This is one that maybe we don't always think of, but for any of you who like other winter sports like skiing or snowboarding, this is common advice, right? When you're going down and if paths are crossing, you need to look uphill to see who else is coming down. And this is to help avoid collisions. Number 6, go where there's light and space. So this is, a recommendation to go during daylight hours. Again, when it's dark, obviously, visibility is lower. It's harder to see those hazards. It's harder to see other people. And so, that's more likely to end in injuries. And then same with space. Make sure that the hill is large enough to accommodate the number of sledders that are there, so that you can spread out and avoid collisions. Number 7, avoid frozen water. This might seem kind of like a no-brainer, but I think sometimes kids get, really excited. Or like, oh, so cool, it's a frozen lake. Let's go sledding across it. Or, let's try and ski or skate across it. This is, not a great idea, because we don't often know how frozen that water is. It might be frozen on the surface, but, the ice could crack and break and people fall in. So it's just a good idea to avoid that altogether. And then lastly, adult supervision. Again, this is more of a kids activity, but it's really important to have adults around so that they can keep an eye on things, make sure they're, paying attention, make sure the helmet's buckled, make sure, reminding kids to look uphill, all those other good things. Adult supervision is really important. And then if there is an injury or a crash, there's an adult there that can quickly attend to those needs. Next slide. And then I wanted to just share a little bit about winter safety tips in general. Sledding happens when it's really cold outside, and so we're not always thinking about some of these other recommendations, but hydration is really important. I think when we get really bundled up, you don't always notice that, how much you're sweating, especially with these activities. They are very physically demanding, and so, you are sweating and losing water, and so staying hydrated is really important. Dressing in warm layers, so you can take layers on and off, is really important, particularly for kids. Sunscreen, always a good reminder. In Utah, we have high elevation, and in the wintertime, the sun reflects off of the snow. And so you're actually, getting the sun from both directions. It's coming from above you, and then it's also reflecting off the snow below you. And so wearing sunscreen is another important reminder as you're out doing winter activities. And then lastly, learn first aid. It's always a good recommendation for families to have just some basic first aid knowledge. And I know all of you would subscribe and agree with that recommendation, but basic first aid is really important. So I'll pause there for just a second, see if there's any questions, and if not, I'll turn it to Lindy. All right, Lindy, I think it's all yours. It always takes a minute to come off mute. There you go.
Sorry about that. Switching between two different devices is always fun. Thank you so much, Jessica. I think it's really important when you're talking about sledding. I don't know how many times you guys heard this, but Jessica said multiple times, this is a no-brainer. And that's something that's really interesting with sledding, that there's so many things that we ignore. And then we just keep going and we're like, oh, it'll be fine. So thank you so much for sharing these safety tips, because it's so important to remember. There we go. So I'm going to start talking about sledding in pediatrics, really, what happens with our pediatric patients and why it becomes a big deal. Here, so like Jessica was mentioning, sledding is almost this instantaneous sport. It's so accessible. You can use improvised equipment. It's not recommended, but it happens. Kids can do this with or without supervision. They'll just hike up a neighborhood hill. It's not something a parent always knows is happening, right? And so what you find is that kids, through their development, they haven't quite figured out concrete decision-making skills yet. That actually doesn't develop until their early adulthood years. So now you have a sport that's easy to do. All it takes is the hill outside their backyard or their neighborhood, and they don't make good decisions. So you can see how something like this illustration can easily occur. So to truly understand why kids get hurt while they're sledding, we're going to talk a little bit about the physics as it relates to trauma. And I know some of this might just be a complete reminder, but I think it's always great to understand what is occurring with your patient and how that injury occurred, and to see if there's any other injury patterns or any other type of injury you should be suspicious of. So, does everyone remember what, 4th grade physics or science? It was so funny. I was putting together these slides and my daughter came and sat next to me and she's like, oh, I know all about this. And she's in 3rd grade and she started like spouting out, and then my other 2 daughters who are older than her started like adding on and was like, Oh my gosh, is it just the adults that forget these basic, really, rules of science and how the world works? So in case you're one of those adults, we're gonna do a really quick refresher here. So let's jump into the laws of motion. The first law of motion, it's illustrated here, but an object at rest remains at rest unless it's acted on by any kind of force, right? This object in motion continues to stay in motion unless it's acted on by another force. So what we find is this ball at rest, it has all this potential energy. This ball moving forward has all this kinetic and in motion energy. And when that force, when that ball stops moving, that energy has to be transformed or transferred somewhere. And unfortunately, when those two objects happen to be an individual and another object, any type of alteration can occur to both objects as that energy is transferred. So next, Newton's second law of motion. This one is pretty simple. You apply force to a mass and you get acceleration. If you apply more force to mass, you get more acceleration. I think this is the definition of what kids are seeking, right? They're always looking for that like thrill ride. How can I make this better? How can I go faster? And I think again, that applies to why we see so many sledding activities, sledding activities, but also accidents. The last little bit of physics I wanted to cover was the law of conservation of energy. Just to remind you, energy can't be created or destroyed, but it can change form and be transferred. So this is basically the definition of trauma, right? You've had something occur, that energy was transferred to your patient's body, and now an injury has occurred. So why should you care about any of what I was saying? Because guys, Bob wants to go sledding. So meet Bob. Bob's our sledder for the day. He gets really excited because who wouldn't be excited with a brand new bit of snow on the ground? This triangle is our wonderful snowy hill. Bob climbs to the top. He's so excited. He applies a little bit of force. He pushes off and he starts to slide down his hill. He builds up momentum or accelerates, building up all that energy. And Bob makes it to the bottom nice and safe. Luckily, this hill had a lot of snow on it. It didn't cause a lot of friction, and Bob got to go really fast, so he was excited. At the end of the hill, again, now he's flat. He doesn't have as much momentum, and so the sled has friction, the energy is dissipated, and he's ready for another try, right? Well, this time our friend Bob, he climbs to the top of the mountain. He forgets to look where he's going. He again pushes off and he's sliding down his hill. He's so excited. Halfway through, he starts to go, oh no, because standing at the bottom of his hill is a group of people. Bob again hits his maximum acceleration. He's super excited, except now he's a little bit nervous because now there's a group of people. Bob has all of this energy build up. He runs into this group of people and there you go, traumatic injury. What if, does it have to be people? I think one of the hardest things to see, especially like during my career at Primary Children's, was the preventable accidents. People sliding down random items, really like using random items, going in random places, sliding into playgrounds, sliding into barbed wire fences, sliding into trees, right? Unfortunately, we know all of that energy that Bob has built up, it has to go somewhere. So as he hits the tree gets some, Bob gets some. And that again is unfortunately the definition of trauma. If Bob chooses to have a friend go with him, this just all compounds, right? More mass, more acceleration, more trauma, okay? So you got through the physics part. We're going to move on to a little bit of pediatric anatomy and trauma and why kids are so special, especially when it's related to trauma. So what makes them more prone to injury? I had to include this because it just made me laugh. And it's a little bit grainy, but as I play it, you'll see. What you have is you have an individual who might be adult age standing at the top of a hill. There's snow, but there's also some weeds. So, you probably are thinking, she won't go very fast. It's going to be fine. They have improvised a sled, just like Jessica said not to, because, it's a baby pool. Why wouldn't it slide down a hill? This is such a good illustration of pediatric anatomy. So hopefully, again, they lead with their heads. She falls over. The parents are like, wait, that was supposed to be fun. That was supposed to be a good thing. But it's just another demonstration of how sledding, easily accessible, can be done with any age group. And even sometimes the adults make poor decisions and get you there. So this is our little pediatric patient. As you just saw, our poor kids, well, maybe not poor, maybe they don't even notice, but our patients, as far as their anatomy goes, they have giant heads. They're so cute, but they have giant heads. And so especially when you apply any type of force or a traumatic mechanism, sledding, falling, these guys lead with their heads because it's large. Even if you don't see an obvious sign of injury, because the patient's head or the pediatric patient's head is so large, you should be suspicious of a head injury until proven otherwise. Next, these cute little guys have very weak muscles. So they have a really hard time holding up these giant bobbleheads. So when you think about that, especially related to trauma, as they are being propelled forward, their head has even more movement than normal, and they have very weak muscles at baseline. So when you apply that, what happens is our pediatric patients have more soft tissue neck injuries than they do bony, like C-spine injuries. The next part is their teeny tiny torsos. In comparison to the rest of their body, they actually have very small torsos. What that equates to and why that is important is because, again, that energy has to be transferred somewhere, right? All of their organs are basically smashed together in this little space. So sometimes what you'll see is you'll have an impact point on the chest, but you don't have any bony injury, so there must not be an injury, right? Not in peds. So what you'll find is you'll have an impact injury, maybe a very small contusion or maybe an abrasion or something, but they have underlying problems with their underlying organs, like a pulmonary contusion because of the impact here and the energy that was transferred. Remember, right here in their abdomen, they have exactly the same organs you do, except they're in a very small area and they're all kind of smashed together. So when they have an impact to their abdomen, that energy is again transferred all throughout that area. And what we find in pediatrics is even a small injury can have multiple organs affected. Another classic thing with our pediatric patient is they have pliable bones. When we were talking about the chest, it takes a significant amount of force to break a rib. And again, if you have a rib fracture, you should be even more suspicious of an underlying injury. These bones because they're still forming, anytime there's trauma, they can actually buckle, which the shaft of the bone just basically collapses onto itself. And these bones are so pliable, and so it takes a significant amount of force to actually break these bones. And so if you have a broken bone, you have to remember or think about, what about the underlying structures? What about the surrounding soft tissue? Is there anything else that we need to be worried about? The last thing I'm going to mention on our pediatric anatomy, and again, I mean, there's a lot of things with pediatrics, but these were some of the things that I thought were important to think about, especially related to sledding. Our patients have a high body surface area compared to their volume. So they have all of this skin, they're outside in the outdoors, they may or may not have appropriate clothing, they might have spontaneously gone outside, unbeknownst to their parents, right? Or maybe they're clothed head to toe and you can't see any part of them. But their high body surface area does leave them susceptible to hypothermia. Unfortunately, hypothermia with trauma then leads to acidosis, coagulopathies, your triad of death. So this is your chance to really affect that hypothermia and protect your patient by using warming methods. Okay, so we've talked about physics, we've talked about anatomy, we did a little bit of sharing, and now I'm going to give you a case study. Okay, so what we have is a 9-year-old girl. Nope, Mel, sorry. 9-year-old Mel. He was sledding with his siblings. He sled halfway down the hill, and then he was like, where are my siblings? So he stopped and he looked up the hill only to be hit in the face by his sister's sled. Parents see this happen. They run up to him. They don't know quite what to do. So they scoop him, they put him in the private vehicle, and he arrives in your emergency department. What do you do? If this is you, if the first thought out of your head is panic, I hate pediatrics, they're the worst, nothing works well with pediatrics, it's gonna be okay. I think the most common thing I hear when I teach any course that mentions pediatrics is, I hate peds, I'm scared of peds, peds, I can't do peds. Guys, trauma is trauma. If this kid was an adult and was 35 and presented to the emergency department after being hit in the face with a sled, would you be worried? I'm gonna guess no, because that's probably what you're used to, right? So again, trauma is trauma. Applying that same systematic approach that you have learned all throughout, probably so many courses throughout your career. Again, we're going to start with the basics. Do you have a team? Do you have your PPE? How about we start with our primary assessment? Same thing, right? Trauma is trauma, so we're going to assess this patient's airway. He was hit in the face with a sled. So high mechanism of injury, direct impact. We have to start worrying about some things. So when this patient arrives and you're assessing the airway, you notice the patient has an unstable face and copious blood in the nares. The patient has gasping respirations. There's a thready pulse, heart rate is 42. There's a large scalp laceration with active hemorrhage. The patient had a positive loss of consciousness on scene. Current GCS is 8. Pupils are equal and reactive to light. As you expose this patient, there's no other obvious signs of trauma, but you notice he's hypothermic, of course. I have to say, I'm not sure if I've ever had a trauma patient who was not hypothermic. So if you have, congratulations. I would like that just one patient without hypothermia. So what are we going to do for our patient?
I'm going to run him to primaries, Lindy.
No, you're not.
Yeah.
You're so not.
And I was going to tell you, adult trauma also come in hypothermic. So I think it's just across the board, sadly.
It's just like their normal idea of what should happen, right? They're like, nah, regulate my temperature. Never mind. I'll keep my organs alive. Thanks. I'm going to say it again, you guys, but trauma is trauma. So does our patient have an airway? Does our patient need an airway? With a GCS of 8, again, if you had an adult who had a GCS of 8, an unstable face, copious secretions, had gasping respirations, would you even hesitate to pull the trigger and establish an airway? No, right? Everyone's going to say, duh, that's like, check, got that one. Same idea. So interventions with pediatric patients, same interventions. Sometimes we just use smaller equipment or smaller doses, okay? So again, trauma is trauma. So your patient is intubated and of course suctioned. And what you notice is after this happens, the bradycardia resolves. So sometimes bradycardia can be part of increased ICP, which again, this patient had a direct impact to their face. And of course, that energy would be transferred, right, straight through the structures to that soft tissue. The other thing to be aware of with pediatrics is the #1 cause of pediatric arrest is hypoxia. So your patient was telling you that he was in trouble, right? Gasping respirations, had an unstable face, how much was coming in and out, who knows? But you intubate, you suction, you control the airway, bradycardia resolves. We place a C-collar, right? Again, trauma is trauma. Your patient was hit in the face, had a traumatic injury occur. Should we be worried about protecting their C-spine? Yes, right? This patient, there's no way they're going to meet nexus criteria to clear a C-spine at this point. Your patient has a GCS of 8, right? So we know that we need to protect their C-spine and we are going to apply a C-collar. Same intervention, just probably a smaller C-collar than what you're used to. You find once the patient is intubated, the patient bags very easily. Thankful, I mean, this is the time you should be thankful for a pediatric patient because peds are so much easier to work with. They haven't developed years of problems and years of bad habits. 99% of the time, your pediatric patient is going to be an absolute breeze once they're intubated appropriately. So your patient's intubated, he bags easily, you feel comfortable with it, you transition him to a vent, okay? Unless you have super strong hands and you wanted to stand there and bag. I mean, more power to you, but I'm not that person. So I would recommend something that has more of a controlled volume rate, you know, something like that. It's time to place some IVs, right? Our patient was intubated with drug assistance, so he probably has at least 1 IV, but we're going to place at least 2. Trauma is trauma, right? Your patient still needs IV access. Again, maybe smaller size, might not be a 16 gauge in bilateral ACs. I will tell you, I don't think there's an appropriate gauge per age. I think there is an appropriate gauge per vein. So some patients, for whatever reason, have teeny tiny veins and all the tricks in the world, that's all you're getting. So establish IV access according to the vein, the site you see, not according to their age. Have I seen a 4-year-old with an 18 gauge? Yes. Do I always think that's appropriate? No. But again, as you're placing in the IV, you're going to gauge that based on your site and what you see in your assessment, okay? Our patient needs fluids. They had a weak pulse, thready pulse. We should probably do something about that. We've intubated and controlled the airway. Let's also support them. As Jessica mentioned, people forget that being outside in altitude or being out in the sun, you get dehydrated. So at baseline, we live in the driest area ever. And so at baseline, I bet you and I are all dehydrated. Then you add any type of exertion on top of that. And your poor pediatric patient who has a high metabolic rate is probably dehydrated too. So again, same intervention, we're going to give fluids, but this time we're going to give a smaller amount. So this is 20 mils per kg. The golden words are always warm isotonic crystalloid. Doesn't matter, whatever you use at your facility, fantastic, okay? Our patient has active external hemorrhage. We should probably do something about that, right? Otherwise, our pulse may not ever get better as we continue to let them bleed. Same idea, you have a wound, control it with direct pressure. And again, same idea of bagging your patient. I'm not a fan of standing there for hours pushing against someone's head. So I would probably put some type of compression dressing on top, keeping in mind where the injury occurred so you're not blocking anything else that needs to be assessed, okay? Again, hypothermic, we're gonna do something for this poor patient, right? It could be anything. We've given them warmed fluids. We could use warming lights. We could use a bear hugger. I find warm blankets are probably the easiest accessible, maybe not the most effective, but probably the thing that we're most comfortable with just grabbing, placing on the patient and moving forward. And lucky for you, your transport team is now at the bedside. Yay! I think it's really important to remember when, like Jamie said, if this patient arrived at her doorstep, she would say, I'm ready, get him out of here. You've stabilized your patient. You're not required to do the rest of the secondary survey. You're not required to do the rest of your imaging. What is most important for this patient is definitive care. So if definitive care is at your facility, wonderful. Move forward, do more. Finish the rest of your survey, do whatever else you have. But if you have a transport team at the bedside ready to take your patient to definitive care, we still would like to protect that golden hour of trauma if we can, okay? So this patient is transported to Primary Children's, subsequently diagnosed with a moderate traumatic brain injury, had a subdural hematoma, multiple orbit fractures in different areas, had a scalp hematoma, of course, with that underlying laceration and subdural. Do you see how all of that kind of what you see wasn't all that you got? There was more energy transferred, right? And they had a temporal skull fracture. So the hospital course, this patient came from an outside facility, was stabilized and transferred via lifeline, had 4 days of ICU care, 6 days of inpatient care, and now has ongoing rehabilitation due to the traumatic brain injury. It's kind of hard to swallow when you see it that way, because when you talk about sledding in and of itself doesn't sound like it could cause significant injuries, but it does. And as Jessica shared the statistics from Primary Children's, those are 30 patients that came in as traumas and were part of our trauma registry. Unfortunately, we're a referral hospital, so we get all of the things from outside hospitals, but as she mentioned as well, that doesn't mean that we captured every sledding accident in the entire, even in the entire Salt Lake Valley, right? We might have just captured those most severe injuries. But again, as a parent, if I'm thinking about sledding, I want to make sure that I'm prepared, my child is prepared, and make sure I'm making good choices so a situation like this doesn't occur. I have another case study. We have time, right? 12.
Yeah, we have time. I did have a question for you real quick as you were talking about that. So favorite method for bolus for kids, fluid boluses?
Oh, I am old school. I like push-pull.
Mm-hmm.
It's using a 3-way stopcock, warmed fluids. I find it to be extremely easy to measure and to give. I can gauge the fill of IV, like of my IV, whether it's patent or not, versus a pressure bag. A pressure bag is another means. Pressure bags are hard because your patient has to be at least 25 kilos to give that 500 ml bag. So then you have to start thinking about patient size related to your volume delivery. The other method, of course, is the Belmont. Quick, fast, easy, warmed fluids, also regulates pressure, which is super fantastic. The reason I like push-pull is because since I have a 3-way stopcock, it's really easy for me to be able to give medications as well as fluids. But There are so many different setups out there. And what I would say to you is use what you are comfortable with. Because if you're giving a controlled amount of fluid and you've never used the Belmont before, putting a liter bag on the Belmont that's gone in what, 2 minutes? And you're like, wait, hold on, I just pressed go. So something like that can cause injury to your patient. So I think it's really important, especially in these high stress energy moments, that you understand what you're doing, how it applies to your patient to protect your patient and care for your patient. Okay. Second case study. A 7-year-old female was sledding with her family. She finished sledding. She was standing at the bottom of the hill when an adult sledder ran into the patient. The patient was thrown about 5 feet. EMS arrived at the scene and now transports to your facility. What do we do? I hope you've gotten my message that trauma is trauma. You're ready for that systematic approach and you're ready to like, da, 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 I'm a superhero, I can do anything, instead of panicking. Okay, trauma is trauma. So let's start assessing our patient. So this patient arrives spontaneously talking, has an obviously clear airway. She does complain of left-sided chest pain. There's decreased breath sounds there, and she's occasionally grunting. Grunting is a really interesting, let's talk about grunting for 1 second. Grunting is a really interesting finding because it's always on expiration. So you'll hear them, and it's actually the patient compensating and keeping their airways open. Your patient is tachycardic, but has strong pulses. She did not lose consciousness. She's a GCS of 14. She opens her eyes to voice, but her pupils are equal and reactive. As you expose her, you notice that there's an obvious deformity to the left lower extremity. What do we do, right? Well, let's start thinking about what type of interventions our patient needs. So when you think about the mechanism, you had a large individual that struck her, threw her, and she landed on the ground, okay? So there's at least 2 areas where she was impacted by this energy. So as far as her airway goes, we already know that her airway is clear. She's spontaneously talking, it's clear, we feel good about that. But she's had a traumatic injury. She's GCS 14, so she's not awake and alert. She has a distracting injury. This patient does not meet nexus criteria, cannot be clinically cleared. It's time for a C-collar, okay? You apply oxygen. I mean, why not? Your patient is grunting, right? Your patient's complaining of left-sided chest pain with decreased breath sounds. Patients after a trauma tend to be in this like shocky state. So any way that you can help them decrease the need on their body, you know, give them a little oxygen. They're going to love you for it. This patient being 7 and awake and alert, well, sort of mostly awake and alert, might pull and give you a little bit of problems, but with a simple explanation, talking to her and using her words will help her understand why it's necessary. Again, trauma is trauma, people. We are going to place some IVs. We had strong pulses, but our patient's tachycardic. Is that due to pain? Is that due to anxiety? Is that, we don't know. We're going to give her 20 per kilo and we're going to reassess to see how she does after. We're going to splint that deformed leg, right? I think it's really important to think about the reasons why you're splinting. Pain, of course, right? Is it to restore pulses? Does your patient have a deformity that has impacted their color, motion, sensation? Do they have a warm foot? Do they have a cold foot? Is this something you need to be more worried about, right? So we place our splint. She, of course, screams because it hurts. You've medicated her for that. And we apply warm blankets. I mean, because why not? Luckily, you're at the facility where she's going to stay. So we then move down our trauma survey and we obtain images as well. What happened with this patient? So she had a mild traumatic brain injury. It wasn't as significant as our previous patient. She didn't have a direct impact to her actual face. Her injury occurred when she was thrown and then landed subsequently on her head because kids have giant heads, right? What we find is the oxygen helps, but she does have a pulmonary contusion. Pulmonary contusions at first glance might be nothing. They end up developing over a time period. Giving her fluids will make it worse. The fact that she's grunting right off the bat makes you a little bit nervous that this is just going to continue to get worse. So it's something that we need to keep in the back of our mind and continue to assess and treat for. As we probably have already realized, this patient had a left femur fracture. This age group is really controversial on how they treat femur fractures versus the old school spica cast. Some of the new ortho docs, even in this age group, are moving to the flexible nail. Kids are really interesting because there's always like new studies. It's hard to get some research because who wants to be like the guinea pig for a research study with a developing child? So it's really interesting, but she will get some kind of, this patient got a spica cast. And if you've never seen a spica cast, they look like old school torture devices because they cast one leg, the unaffected leg, usually to mid-thigh. They cut out a hole so you can still use the restroom. And then the other leg is usually splinted down to like mid-shin. And there's usually a giant bar in between the two holding them in place. So you can imagine mobility. How do you get this patient to the bathroom? How do you get this patient in a car? How do you move this child from here on out? So things like that are why this patient not only had that EMS transfer, spent some time, and of course, in the emergency department, had 3 days of inpatient care. Again, goals for inpatient, same thing that you're looking for with your adults. Nutrition, pain, mobility. Are you safe to go home? Are you not safe to go home? So this patient did receive inpatient rehab to address that. Conclusion, these are your takeaway points. I hope everyone is like writing them down or ready to write them down. Sledding accidents are 100% preventable. Following basic safety tips prevents injury. Knowing the physics, mechanism of injury, and anatomy helps determine your injury patterns. Trauma is trauma, even when related to our pediatric patients. Here are the resources that Jessica and I used. And then do you guys have any questions for us?
Everybody's so quiet today. I'm going to launch the poll while we are waiting to see if anybody's got any questions. Thank you to both of you. Fantastic. I love that. We'll actually find the right poll. There we go. It's good because I don't usually get to do the pediatric stuff very often. So I love it to bring the pediatric world to our audience. And it helps when I'm trying to teach things that I know a little bit more.
I feel pretty spoiled to get to focus just on kids. Kids are kind of their own little beasts and it's fun.
Yes, well, as Tia put out in one of the presentation that I saw her over the weekend, a lot of people are woefully unprepared for a disaster, including pediatrics. So yeah, it's always good to just get the pediatric tips and tricks and remember that they're probably going to be coming to all hospitals no matter what you do.
Right. I think that's a really good thought because if you think about the location of our pediatric facility, it's where you guys are. You know, it's way out on that east bench. It's isolated when you think about large freeways to get there. Learning more about the Las Vegas shooting, I start to try to think about what would happen for a disaster in the Salt Lake Valley. And it worries me because the level 1 trauma centers, there's 2 that are a little bit on the isolated side. So that leaves a lot of community hospitals and 1 level 1 trauma center to care for mass casualty incidents or to stabilize and transport. So I don't think we can say that something will never happen to us. I think it's better to be prepared.
Exactly. Well, definitely, if there's no questions, everybody's doing in the chat, great presentation, very informative, saying thank you. I appreciate you, Lindy and Jessica, both for doing this today. And hopefully we can continue to collaborate in the future. So thanks again, everybody. Have a great day.
Thanks for having us.
Mhm.